Hello and welcome to the Christopher and Dana Reeve Paralysis Foundation professional webinar. Today, we're going to be talking about some functional electrical stimulation, which is something that has come to fruition after years and years of study. But I would first like to thank our audience for coming today. I'd like to thank all those people who have donated their bodies to the clinical trials for these studies that have gone on and continue to go on, for those who've donated financially, and for those who have sent their positive thoughts and hopes and dreams in this project that we're starting to see just at the beginning of steps to completion here, fruition. We'll hear more about that later, but some paralysis, spinal cord injury, or paralysis from head injury or medical diseases is not a cheap option. And so not everybody has money to be able to support different endeavors. And I know that all too well from walking that walk with you all in my own personal life. So just even positive thoughts. I want to thank everybody who has contributed so generously to all these studies. So today we're with the SpineX Corporation, and Parag Gad, PhD, is the CEO and co-founder. So I'm going to turn it over to Parag to start talking about the background of SpineX.
Thank you, Nurse Linda, for the opportunity here and inviting us to this amazing webinar. We are honored to talk to you about some of the technology that we're developing here at SpineX. I have here with me the rest of the SpineX team. I'd like to quickly introduce them. We have Kara Alenak, our Director of Product. We have Dr. Evgeny Craden, our Chief Medical Officer and co-founder, and we have Dr. Gabe Kalmer, our Chief Operating Officer and a board member. If you're okay with it, Linda, I'd like to share my screen and just sort of give you a visual of sort of some of the technology that we're developing.
Absolutely.
How's that?
Perfect.
Perfect. Thank you. So before we begin, just want to sort of take you on a quick journey of how the nervous system operates. Now, we have probably heard in school that the spinal cord is a channel for communicating brain signals to the rest of the body. After an injury such as spinal cord injury, the communication between the brain and spinal cord is disrupted, which is what leads to loss of function. What we have developed is a technique known as non-invasive spinal neuromodulation, which is the result of years of research done by a much larger team that results in improvement in function. And what we really identified is ways in which we can electrically activate this nervous system to restore function and rewire how the brain communicates with the rest of the body. So we use very low intensity electrical pulses that are delivered to the spinal cord in a non-invasive manner, non-surgically, by placing hydrogel electrodes at different levels of the spine. Now, due to the spinal cord injury and the disruption of nerve signals, the spine and brain are still communicating, but the nerve signals there are weak. By electrically neuromodulating the signal, we're able to amplify some of these weak nerve signals that are present. And by amplifying some of these weak nerve signals, we allow the brain to hear what the periphery is trying to say and allow the periphery, or the muscles of intent, to understand what the brain wants it to do. Based on this platform technology, we have created two products. SCONE, our adult device, is intended to treat neurogenic bladder symptoms in individuals living with paralysis. And SKIP, our pediatric device, is intended to treat movement disorders in children living with cerebral palsy. Now, to note, both SCONE and SKIP are still investigational devices, and the required FDA trials is ongoing before the FDA would clear them. Now, based on early pilot results, we have identified that we have been awarded a breakthrough device designation, which essentially classifies both SCONE and SKIP as novel devices in this field. The way it operates is by electrically delivering these low-intensity electrical pulses. We're able to reactivate these weak nerve signals and amplify them, allowing the brain to hear what the periphery wants it to say. Now, with early pilot results from clinical studies done in the academic setting. We have worked with about 30-odd individuals living with neurogenic bladder and observed a 10-point or greater decrease in the neurogenic bladder symptom score, which is a metric of overall bladder health. And now that translates to about a 70% reduction in incontinence episodes and a 40% reduction in voiding frequency, restoration of sensation of bladder fullness, restoration of bladder capacity, allowing these individuals to catheterize based on sensation rather than the clock. Now, again, these are early pilot studies that have been conducted by the team that are reporting these results. What we also observed in individuals living with a stroke, and this is a study that Dr. Craden recently published, is due to the stroke, the activity in the brain is decreased, as you can see from this panel in between, compared to healthy adults. But after scone therapy, we're able to restore the same activity that is responsible for controlling bladder function after just 12 weeks of scone therapy. What this also identifies is that the improved function is not only present when the neuromodulation is actively being delivered, but there's enough neuroplasticity that you're able to induce in the brain and spine, allowing the function to be retained even in the absence of active neuromodulation. Now, based on these pilot results, a pivotal trial for FDA registration is ongoing at multiple sites around the world, and we anticipate this trial to be completed in the coming months. Here are some of the sites where the trial is ongoing. So if some of your users who are individuals living with neurogenic bladder and would like to participate, they can reach out to the sites to participate in this ongoing pivotal trial. And to quickly touch upon our pediatric device, SCIP, which treats movement disorders in children living with cerebral palsy. Cerebral palsy is the most commonly seen movement disorder in the pediatric population. And here's an example of a child living with CP after having undergone standard of care physical therapy his entire life. Now, if they're limited to standard of care, this child would be needing a wheelchair for mobility reasons and would also be living with multiple comorbidities for the rest of his life. When we treated him with SCIP therapy on the first day, we're able to regain voluntary stepping in this child. Now, here again, to note that the therapy is completely non-invasive. We're not causing any pain or discomfort to the child, and the walking is voluntarily driven. Unlike muscle stimulation or TENS, we're not inducing muscle contraction. The child is voluntarily able to step. And this was the effect of 1 day of treatment, the first time he was ever treated with SCIP therapy. When treatment was continued to be delivered more frequently, 1 hour a day, twice a week for a period of about 16 weeks, this is him at his home in the absence of active neuromodulation, being able to take steps on his own volition. I'm sorry, being able to ride his bike, something which he could not do earlier. This basically highlights the degree of improvement that is possible and the fact that neuroplasticity is being induced in the brain and spine, and the improved function is retained even in the absence of active treatment. So that in a nutshell is SCONE and SCIP and the technology we're developing. As I mentioned earlier, both SCONE and SCIP are still investigational devices, and we hope to have these on the market in the near future.
So I love your phrasing of using the hearing aid for the spine. That really explains a lot. And I noticed in the pictures of the mapping of the brain and the responses, makes me think of the early studies done with Christopher Reeve and the functional MRI studies, where he was doing electrical stimulation on really old equipment now. I mean, those huge FES bikes that, you had to have a room in your house to have one. And they were a challenge for people to use, but it certainly showed different mapping in his brain, which showed that neuroplasticity, which you also demonstrate. And do you have any further thoughts about neuroplasticity in the brain and how that might work?
So I think that there's some ideas. I don't think we've ever been able to really establish what that neuroplasticity exactly looks like. And again, here putting on a researcher hat, the brain and spinal cord are connected, and they're communicating. And the spinal cord injury is essentially disrupting the communication. I believe there's a study from Australia from the late 90s where they studied SCI individuals or cadavers that had SCI, and they observed that 97% of individuals classified as clinically complete and functionally complete were actually anatomically incomplete. So there are still some of the spare nerve fibers that are communicating between the two halves. These signals are weak and they just cannot be interpreted to the other side. With the neuromodulation, we're able to amplify some of those weak nerve signals, allowing the other side to hear what is being said. But because everything is connected and they're all sort of intercommunicating, neuroplasticity is being induced both supraspinally in the brain as well as at the spine level itself. And I think there's now enough functional evidence out there. We don't know what is exactly being turned on or what is being reactivated, but the fact that neuroplasticity is present from a functional standpoint, I think is now well established.
Just second what Parag, oh, sorry, go ahead, Linda.
No, go right ahead.
No, just to second what Parag was saying, in my mind, there's actually no question that neuroplasticity is induced, as we showed in that fMRI study. And while that study focused on stroke survivors, I'm sure we'll see something similar in patients with spinal cord injury. The reason why I say that is also because of the results that we've seen in the published papers that show improvement in sensation of bladder fullness, right? In patients with spinal cord injury, right? And unless you're activating parts of the brain that are responsible for sensing bladder fullness, there's no way to elicit that conscious sensation. We know that the brain is responsible for conscious sensations that we're aware of, right? And that tells me, we haven't shown this with functional neuroimaging, that we are activating parts of the brain that were inactive before. We're inducing that neuroplasticity.
Well, and I know in the community, I think one of the biggest issues is just in terminology, because when we do the Asia assessment, people have a complete or incomplete injury. And that terminology, which worked when the assessments were devised, has confused people, healthcare people, as well as people in the community, because they hear, oh, you have a complete injury. So they automatically think their spinal cord is completely severed. And as Dr. Gadd pointed out, in looking at people, it very rarely is completely severed. It's almost impossible to completely sever the spinal cord injury, either through trauma or through disease. And so there are always those little fiber connections. So I love that hearing aid, going back to that hearing aid amplification. So making that sound, and certainly Dr. Creighton, the way you explain it, it's like, oh yes, so the brain is multifunctional. It has, people identify the brain, they look at pictures of the brain, and this spot is controlling this, when really the brain all works together.
Mm-hmm.
It all communicates together. So taking advantage of these things that are pieces of the puzzle that are not clearly defined, and yet we know that we can harness that. That's pretty spectacular. So there's a couple of questions that have come in right away. And so let's talk about them while we're in, especially talking about bladders. So there's a person who's had a suprapubic catheter. They're 20 years post-injury. And anyway, they wanted to talk a little bit more about people with suprapubic catheters and using the device for retraining the bladder. How does that work? Have you done it with people with suprapubics, or is it just straight cath? Give us more information on that.
So the current trial, the current focus has been on individuals that are either volitional voiders or are intermittent catheter users. I think I'll let Evgeny answer on the clinical side of things, but just from a company point of view and the trial that's ongoing for FDA registration, it is limited to individuals that are CIC users and volitional voiders. Evgeny, you want to expand on the potential with suprapubic, please?
Sure. So, Susan, just to answer your question in the chat, in the urology world, we always think of indwelling catheters for patients with neurogenic bladder as kind of the last resort, right? I think that thinking has changed in the last 10 years. Certainly it's changed as I've been in clinical practice independently. Some folks just are best served with an indwelling catheter like a suprapubic tube. To answer your question about care, it's very similar to care for a Foley catheter, which is a urethral catheter. It's essentially the same type of catheter, the same type of care, that it needs to be exchanged every 4 to 6 weeks. It provides continuous drainage of the bladder. There are risks, of course, of infection, risks of stone formation, things that are also there with an indwelling Foley catheter that goes through the urethra. In terms of where this technology could be applied for folks with suprapubic catheters, I think that, again, I think of a suprapubic catheter or indwelling catheter as not quite the last resort, but a situation where we're like, well, we don't have anything much left to do, so we're going to put in a suprapubic catheter so the bladder's drained. So I think that the hope with this device and the hope with this technology that we would be able to prevent that from happening. That would be able to restore some sensation, restore some volitional voiding eventually, and avoid putting in a suprapubic tube in the first place. But that being said, I think that because of the potential of neuromodulation to improve hand function, this is one of the main reasons why folks get a suprapubic tube for management of the bladder. The potential of this technology to improve hand function, right? If we can improve hand function, we can improve bladder function. We can hopefully get patients suprapubic tube free and indwelling catheter free in general.
Okay, well, let's follow up with the next question here. It says, does this technology aid complete SCI from trauma? But I'm going to add to that, does it make a difference if the spinal cord injury is from trauma or disease? And I'm also going to add to that brain injury stroke, because you had mentioned brain issues. So can you talk a little bit more about different levels of injury? If it's in the brain or in the spine, does it make a difference?
So again, going back to some of the work that we did over the last 5 years that's now published and available in the public domain, we have seen positive results from these pilot studies in individuals with complete injuries, as well as with cortical strokes, and even individuals that have spinal cord injuries due to non-traumatic conditions. So the cause for injury is not what drives the improvement in function or determines improvement in function. It's what we observed is that if the spinal cord is responsive to the neuromodulation, then you have a higher likelihood of the individual responding positively. So a stroke, a spinal cord injury, presents with similar symptoms, which is reduction in voiding ability, loss of sensation, reduction in bladder capacity, increased urgency and frequency, which have a direct impact on the quality of life of the individual. So yeah, the short answer to the question is yes, the cone therapy can positively impact each of these pathologies and is not dependent on what caused the neurological trauma in the first place.
Okay, and how can healthcare professionals, nurses, physical therapists, occupational therapists, how can they get involved in helping people with these devices?
So we're in the process of setting this up, as we get closer to our FDA registration completion, in creating, programs wherein we'll be able to communicate to the general public as to how is it that cone therapy could assist the individuals that they care for. So be it a nurse, a neurourologist, or a PM&R physician, a physical therapist, providing them with the right tools and the right information that they can then communicate to their patients and the people that they care for, and how can they then get access to cone therapy as for clinical use. So as we get closer to our FDA registration, you'll see more information that we'll be putting out in the public.
And let me ask you a question that comes up so frequently in the community. So once you have the FDA approval, will this be an insurance device that people would be able to get anywhere?
Gabe, you want to take that?
Well, I mean, the short answer is yes, they can get it. Initially, it will be pay out of pocket, but our aim is to get this covered by insurance, and that will be a process that we will go through.
And can you disclose at this point in time a price point? Just so people know.
Um,
And if you cannot, that's
No,
okay.
no, we can't at this point.
Okay, so, but it's coming.
It's
And
coming.
yes, it's coming. There's a question about the skip. And somebody writes in, is it possible for adults with CP to see improvement with a skip? It's kind of unusual that you have a pediatric device coming out before an adult device. So maybe you want to talk about both of those aspects, because it's wonderful that the pediatric patient is being put forward. But there's two questions there. Is it possible for adults, and will there be an adult device?
So theoretically, yes, adults with CP could benefit from skip therapy. So skip and scone, stem out from the same platform technology that the company has developed. So essentially they use the same basic ideas that the company and the science behind it. Skip therapy itself was originally designed as a pediatric device, but has been adapted to the adult population as well. And just last week, we in fact had a case study published wherein an adult living with cerebral palsy at the age of 60, having undergone 8 weeks of skip therapy, demonstrated improvement in function that was greater than standard of care. So long term, we do anticipate skip therapy being available to the adult population that are living with cerebral palsy, and we do anticipate that it would benefit them as well. How that would look like and what kind of benefits to expect and what the training protocol there would be still needs to be determined and worked out. But in theory, yes, we do anticipate that a positive response is expected.
Okay, so that's some hopeful news too. There's a person here that says that 112 days after Christopher Reeve was paralyzed, he was diagnosed with cervical dystonia, and he would love to work in research to help find cures for neurological disorders. So, and he has a little quote that he's coined here: "Our mission should not be complete until the wheelchair is obsolete." That's a nice little quote there. Are there any research openings at SpineX for people to contribute to participate? How would they get involved in your studies?
So we have our clinical trials listed on clinicaltrials.gov, where all the sites that are actively recruiting for the trials are listed. Our current major push is to get the scone continence trial complete in recruitment. We're getting close to having that completed, and this is the one that's focused on the neurogenic bladder condition. So anyone that's interested in participating can reach out to any of the sites that's closest to them, and work out and identify if they meet the required inclusion/exclusion criteria or not. If they require more information, they can send us an email at info@spinex.co, and we're happy to share the study sites with them.
Okay, good, because you had that list, or all this, the list that you presented, all those different sites are doing the studies. So that's a good, a good stage for across the United States. Any outside the United States?
We have one site in Canada that is actively recruiting. This is in Vancouver at the ICORD, and we have 2 sites in India that are actively recruiting for the same trial as well.
So there's a question there. Are you still enrolling people? And I believe you said yes, you're still enrolling people. So it's not too late. You can get on this and still participate in this particular study. And at all these different sites, there hopefully is someplace. There's still a lot of the US territory out there that, you might not live close enough, but there's still a lot. But also you'll see in the chat box, there's the site that Dr. Dad mentioned, that clinicaltrials.gov. You go to that site, type in spinal cord injury, and all the clinical trials, anything, SpineX, any place else is still going to be listed in there. And here's again the clinical site. So you can see there's California, DC, Colorado, another in California, Boston, Minnesota, Florida at the Miami project, I assume. Shepherd Center and Craig are both on there. The Canadian one is listed there. Oh, and then New Delhi, India. So that's an interesting site too. So there's an opportunity. We have a lot of questions from people from India. So I'm very happy to see that, because we get a lot of questions from that population that live there. in that country.
Yeah, we've in fact added one more site to India just last week. So now there are 2 sites in India that are recruiting, both in New Delhi. So there definitely is scope for people to participate, not just in US, but also in outside of US as well.
Linda, I put the link on our website to the clinical trial sites, and there's a link there where people can also reach out if they have specific questions.
Great, great. Oh, and there it is right there. There's a question here about somebody wrote in, they wanted to know just about general care for the suprapubic catheter, and that was directed at me, so I will just say the suprapubic catheter requires a dressing change. Your individual healthcare provider will tell you if there's anything else that they want done. So like a new one would require more frequent dressing changes, and if there's anything else that they need to have done, if there's any flushing or something, which is not typically done, but if there's any kind of installations or anything like that that needs to be done, or otherwise it just is there and you change the dressing, and that's keep it clean and dry, and those are pretty much the rules for that. Let's see. Here's a question from someone who is asking about the scone, and it says, can this be used to induce urinating out of the penis versus intermittent cath? Tried pelvic therapy with no success.
So voluntary voiding is the next goal for the scone therapy. So currently the focus is on storage, restoration of sensation, and restoration of bladder capacity, and reduction in urgency and frequency. So while a spinal cord injury impacts the inability to void, it also has a global impact on the lower urinary tract or the bladder. So we are currently focusing on treating some aspects of the neurogenic bladder symptoms. Eventually, the goal would be to restore voluntary voiding as well, but that is not the current goal. That is something that we would address in the future trials.
Okay. So something more to work on. Now here's the question. I think you really have already answered this, but it's come up a couple more times. So, the audience is putting you guys on the spot. And I think that I would like to just reiterate that while these things are in FDA review, there are certain things that cannot be said until the reviews are completed. Is that correct when I say that? Okay, so we have to be a little bit cautious because we don't want to interrupt that in any way, shape, or form. But there is a question about when do you see these available for home trial? When do you see that restoring function and ambulation in SCI, which would be a different device, in times? So when do you see the devices ready that you have now ready for home trial? And then a second question of when do you see an ambulation device in less than 5 years, 10 years? So we're really putting your feet to the fire on these. Look into the magic mirror and predict.
Yeah, I'm going to let Gabe take this one.
Okay. So with respect to the scone device, the scone device currently is in trials. So it's a class 2 device, which means that you'll be able to access the device if your treating physician gives you a prescription for that device. And therefore the care is the responsibility of your treating physician that provides you with the prescription. So initially that device will be available for use in the physician's office, or for individuals who are going into a day program or something like that, where they come into a medical facility of some form, they'll be able to access the device. We do plan to run subsequent trials that are called post-market trials that will allow us to expand our label with FDA, assuming they can grant us that will allow the device to go into the home. That requires, first of all, of course, safety testing, and also requires for us to be able to provide the adequate training program so that they can be efficaciously and safely used in the home with the assistance of a caregiver. So that is going to be a couple of years behind probably, but it's super important for a company that if we're going to put a product out there, we know that, well, first of all, we know that it's safe. That's like, that's critical points 1 through 100. And then, of course, that we provide the training so that people are happy with the results that they get. And that takes time. I mean, the reality is, everybody has their own way of doing things. So it's the responsibility of us or any medical company to make sure that that training takes as much of that into account as possible. With the skip device, that is being designed and is contemplated to be used in conjunction with physiotherapy. It's an adjunct to physiotherapy. And as such, there's no direct path contemplating that in the US market towards home use, unless individuals, and it will be a very small percentage of the people who actually have physiotherapy coming to their homes. In almost all cases in the US market, that is done at a remote site.
Okay, there's a couple of questions about the two devices. First, going back to the scone, there's a question, are children included in the scone trial? And can you tell us why they are or why they are not?
The current SCONE trial is focused only on adults living with neurogenic bladder, including stroke, SCI, and MS. We need to start somewhere, and we've started where with the most amount of information we know. Pediatrics is a more sensitive field and has a high risk profile. So the adults is where we've begun, and the intent would be to first get a label for the adult population only. The skip device, on the other hand, is designed and has all the required features, safety features included for it to be a pediatric device, which is where the clinical trials will be conducted.
Okay. And I believe you already answered this, but this question's come up several times here. Can the skip be used in adults or even with adults with CP? And I believe you've already answered that, but and it ties into the scone. You have your product and you start it in a population and you have to demonstrate it in that population. You can't really switch back and forth. You can't open it up. There are different rules for adults and pediatrics. So I think we've kind of covered that already. So we'll move on down here to there's a question about skip, but it doesn't say if this must be an adult person. I'm thinking they have long-term damage from a spinal AVM. So when skip would become available to adults, would it be for that kind of condition? And that's really speculating, I realize.
Yeah, right now, I think the limitations for SCONE and skip are established, where SCONE is intended to treat neurogenic bladder in adults living with spinal cord injury, stroke, and MS. And skip is intended to treat movement disorders in children with CP. That's the scope of the indications that we plan to cover and the label that we would expect in the future from the US FDA.
Okay, but that doesn't exclude things from the future, I will assume, but we're under this veil of the FDA right now, so we have to be very clear on what the parameters are for right now. So in the future, we have future dreams, and we will all be standing behind you, pushing you along. But right now we're under the umbrella. Okay, here's a very specific question for our urologist, Dr. Creighton. My capacity is helped by Botox. I have chronic reflux into someplace between clean intermittent casts. Would SCONE promote healing of the reflux?
Good question. I wish I knew what LH was into the LH. But the idea to answer the question if we take the LH out of the equation, the idea is absolutely right. The idea of scone is that just like Botox will improve your capacity and allow you to store better, but in addition to what Botox accomplishes by allowing your bladder to expand and store more urine, it will also restore some sensation of bladder fullness, right? So you'll know when to catheterize, as opposed to the way that most folks with spinal cord injury do it now, where they do it on a schedule, right? Or when they start having autonomic dysreflexia or some weird sensation. So that's the hope of scone, that in addition to improving your capacity, just like Botox does, it will also improve your sensation.
Okay.
I'm going to put on my engineer's hat and want to add one additional point to that. Sensation is like an internal GPS system. And what we hope to do for scone to do is to help restore some of that sensation. So your GPS system can kick in and let you know where you're at and what your internal status is of your bladder. So they really think of this as a GPS system. So if you want to go from point A to point B, you really need to know where you are at point A. And that's how we can potentially envision scone working in this population.
Okay. Here's a question about somebody is, this was written in previous to the session here, but there's a question about somebody who's having difficulty in getting technology for his issues. And he wants to know how he can get involved in the developmental part of technology. So how do you at SpineX include the community in development, even pre-clinical trials? And do you have focus groups, or how do you connect with the community to see what their needs are?
Chiara, do you want to take that one, since you and Gabe are closer to that?
Mm-hmm. Yeah, sure. So we do a couple of things. One thing that we do is we connect one-on-one with people in the community who are interested in sharing their experiences with us and helping us to understand better the needs of people who are living with these conditions. And then we also work with NASCIC, the North American Spinal Cord Injury Consortium. And we're actually in the process right now of recruiting for some focus groups where we'll be looking at the scone in particular and some of the user interfaces, and also just gathering more information from both people with spinal cord injuries and care partners about how they would envision using the device. So if anyone's interested in that, we can share some information about how to get in touch with people to participate in those focus groups.
And so you could go to that information link and request. And also, may I say, if you guys are starting something and you want just a general announcement to the public, you can always ask Nurse Linda to post it, and she'd be happy to do it. So don't forget you have that option at all times, because we do have a good connection as well. And so, sometimes it's hard for people to find individual study information from different companies. So, if you need a large number of people, hopefully we can help in that regard. So
Awesome.
what kinds of things do you have in the pipeline? What's coming? What's the future look like for SpineX?
I think we focused on getting these two products to market. I think that's the number one priority for the company, is to get a product to the market so this technology can start benefiting the individuals living with these unmet clinical needs. The SCONE trial is close to completion in recruitment, and we're hoping to have this in front of the FDA later this year and get it on the market as soon as possible. Our second product, SKIP, which focuses on the CP population, we're hoping to have the trial started later this year as well, and that will be on the market in a couple of years. So we are laser focused on getting these two to market and get the individuals and hopefully have them benefit from these, and then go from there.
Okay, so that's actually a lot of work in a couple of years. That's a lot of work. There is a question that was written in here that, this was just such a wonderful question. I can't go without bringing it up. But there was a question about, did the scone, I'm assuming not the pediatric device, but there was a question about if the scone helped sexual function as a side effect, a positive side effect.
So this particular trial that's ongoing, the scone continence trial, is also monitoring for improvement in bowel function and sexual function in both the male and female population. We obviously don't know what the results are, but that is something that we will be reporting, when we have the trial published, and we will be knowing the results of the trial along with the improvement in bladder function. So it is a trifecta effect that we're hoping for, which is a combination of bladder, bowel, and sexual function that will be impacted by scone therapy. I unfortunately can't comment beyond that at this point, since the trial data is still in the works, but we're hoping that we'll have more information in the coming months.
And I just want to point out, that's a research thing. It dirties your study if you start predicting outcomes or start reporting too soon, because then that kind of gives a bias to it. So that is a research thing. That's not anything that's being withheld. It's just that is the rules of research. It has to be that way. And we want it to be safe. We want it to be unbiased. So we appreciate your conscientious effort in that regard. There was a question that somebody wrote in about, particularly about lower motor neuron function, if the scone it works in lower motor neuron. And I'm trying to think back when you listed the different things. I'm not sure if that was specifically stated, so we'll address it now.
So there are some limitations in terms of the level of injury that we are studying in the current trial. In the current trial, we're limiting the individuals with complete injuries to T8 vertebral level, and ones with incomplete injuries down to L1. So there is some low motor neuron injuries that we are covering. So with individuals that have injuries down to T12 L1, we will know the effect of scone therapy for improvement in bladder, bowel, sexual function. But it's not going to cover all aspects of lower motor neuron injury to begin with. That is a more complex condition and requires more investigation, and that's something that we may take on in the future. There are certain boundaries that we're working within for the current trial, but we do hope to have some indication of whether it will impact individuals with incomplete injuries around that level.
Okay. And does it help people who have had spinal surgery?
That's too vague a question. If any thoughts?
Yes, absolutely. I mean, I think that that, like Parag alluded to earlier, I don't think that the mechanism of injury matters so much. And whether the injury is from whether it's iatrogenic from surgery, whether it's from trauma, whether it's from a tumor, I don't think that plays a particular role in the effectiveness of this device. And if the question refers more to, will it work if I have hardware in that space? We've worked with those patients in our academic and in our preclinical academic studies, and we have not seen that interfere with the efficacy of this device.
And I would assume that's with diplegic patients as well. There's a question about diplegia.
Sorry, I'm a urologist. What is diplegia?
Yes, with the diplegic patients as well.
Yes.
Okay. So that's an umbrella answer as far as it doesn't matter what you've had done or what you have, it's going to help you. Does SpineX or skip help with spasticity, especially in legs and hips? And it's for individuals with CP, and I'm assuming that is basically with spasticity or tone.
Yes, again, going back to some of the early studies that we have conducted in the CP population, we have seen the spasticity being an improvement in the spasticity symptoms in these individuals, both for the pediatric and the one adult case study that was published recently. and we do plan to study this in more detail as part of the pivotal trial that Skip would undergo in the near future. So I think the spasticity is something that we do hope neuromodulation will impact positively.
Okay. There's one other question here. Does SpineX know why there seems to be a functional decline with CP? Do you have some physiology behind that?
I don't think it's been studied well enough to answer that question, and I think our focus is more on the improvement in function rather than the decline of function. So I don't think I'll be able to answer that.
Okay. There's a question here. If you can help me kind of figure this out. Is this procedure appropriate or suitable for neuromuscular disordered muscular dystrophy individuals who receive tracheostomy to mitigate aspiration pneumonia? So I'm not sure which device that would be.
Neither of our trials are looking at that per se. That would be a pulmonary neuro effect. We're looking at in the SCONE device, we're looking at your neurogenic bladder, so can't really answer that. I don't know, Evgeny, do you have any more you want to?
Well, we do know we did publish a paper a couple of years ago on improvement of respiratory function in patients with cervical spinal cord injury using the SCONE device, right, Parag? So while Gabe is absolutely right that this is not included in the trials that we're doing right now, it's something that we do have preliminary evidence for, at least for in the setting of diaphragmatic injury due to the spinal cord injury, or diaphragmatic dysfunction due to the spinal cord injury.
Okay, and now we're kind of getting into the weeds a bit with the questions, because there's somebody, now people are asking about their individual cases. So somebody's asking about a spinal fusion. Would it be able to improve lower extremity function? And I think that Gabe has given us the answer that it can affect a lot of people regardless of their injury or disease. So I think we're kind of getting in a rotation here. So let me just ask you, since we're coming up to the end of our session here, what would be the 3 take-home points that you would like the audience to know based on the discussion today and based on what you know from living this life that you have been working on this project for years and years? What are the 3 things that people really need to know? And if you want 4 things, that's fine too.
I think I'm going to start with just one, and then I'll let the others chip in. I think the one that we really want everyone to take away is neuromodulation as a technology is close to being reality, and we do hope we appreciate the patience that people have shown and on the support in being part of the trials and getting us to where we are at. But we are getting closer every day to having the trials completed, and we do hope to have this on the market sooner rather than later, so it'll benefit the individuals that live with these unmet clinical needs. Gabe, Evgeny, Kara, your 1 point each.
I think my 1 point from this would be that we are providing a external non-surgical solution, we hope, here as we run our clinical trials, which will give patients an opportunity to improve their health in a very safe way. That's very exciting because that gives physicians like Evgeny another very important tool in their quiver before they go to something that is much more invasive and requiring a lot of longer term intervention, longer term care, and potential chronic challenges that perhaps weren't there before.
And a lot of danger too, because a lot of people who are in the community with paralysis or people in the world do not realize surgery is not without its consequences. So
and it's not readily available either in a lot of places outside of the US and a few countries in the EU.
Right. And Dr. Creighton, what's your point? What's your
I mean,
take home point?
I would say that, as a physician, I can say that we've figured out a lot of organ systems at this point, how they work, how to manage their dysfunction, how to address the problems, how to help the patient. But the nervous system is still this black box. And we're really, really bad at making the nervous system better, even though it's such a critical portion of daily living. As a urologist, I see this every day. And I hope that neuromodulation technology, like the technology that we're offering here or we're developing here, is a step forward in us being able as a human race to address neurological problems and to correct how the nervous system malfunctions.
Well, and I have to say, you guys all deserve your congratulations for doing as much as you're doing in this. As you say, it's still a mystery, but my goodness, how you have propelled the treatment. And, we have a lot of people in the community that they want this afternoon. We have a lot of people who are, well, let's see how it goes, and then maybe I'll consider it. And then we have some people who say, you know what, I'm fine with the way things are, and, I'm good with that. They're all, right for that individual, but we really appreciate what you're doing and the progress that you are making in this. When you're living it, one day is a day too long. But when you look at it from a scientific point of view, it's phenomenal what you have done. So thank you very much for all of that. There was a question in the chat box that people wanted to know how to get in touch with Nurse Linda. You can go to the Christopher and Dana Reeve Paralysis Foundation and log on there. There's a blue button there that says Ask Nurse Linda. Just click that and you can type in your question. We also have a webinar on the last Wednesday of the month where you can write in your questions, and I just talk for the hour. And so sometimes I think, oh, this won't go on for an hour, but yet I find I can, which is kind of shocking to me. So anyway, thank you everybody for your participation today. You've had wonderful questions. I hope we have answered some of your questions. And again, I wish you all at SpineX much success in the future, because we're all counting on you. The pressure's on now. All right. Thank you so much.
Thank you, Linda, for having us.
Yeah, thank you so much, Linda.
Thank
Thank
you.
you.